So it gives me great pleasure to introduce the speakers of the third session today. We have a great range of topics covering different histotypes, so I'm excited to hear about the research today. So first up, we have Dr. Bo Gao, who is a medical oncologist at the Blacktown and Westmead Hospitals and clinical associate professor at the University of Sydney. So Bo completed a PhD in 2013 on ovarian cancer and has led multiple phase 1 studies of new cancer drugs in lung, head and neck, and ovarian cancer. So I think we're going to hear about some of those today. Thanks, Bo.
I would like to thank the organizer of the meeting to give me the opportunity to discuss about clinical trials in the low-grade serous ovarian cancer. Low-grade serous ovarian cancer is a rare histological subtype of epithelial ovarian cancer. The estimated new case numbers each year in Australia is about 80 cases, and globally is about 15,000 cases. Patients with low-grade ovarian cancer tend to present at a younger age, around 50, so about 10 years younger than the high-grade serous ovarian cancer. Despite that, currently there's no evidence of a genetic disposition. Like high-grade serous ovarian cancer, most patients with low-grade present at a locally advanced state. Stage 3 is the most common, but they tend to have a more protracted clinical course. Similar to high-grade serous ovarian cancer, primary cytoreduction reduction surgery with no residual disease remains still the most important prognostic factors. Currently, carboplatin paclitaxel is still the standard adjuvant treatment with patients with stage 2 to 4 disease. But in a retrospective analysis published previously, adjuvant chemotherapy treatment was not associated with improved overall survival. In the recurrent settings, the benefit for chemotherapy treatment is very limited, so is endocrine treatment. Given that 80% of the low-grade serous ovarian cancer had a positive ER and PR expression, there has been lots of interest about using other endocrine treatment in maintenance setting and the recurrent setting over the last few decades. In a retrospective analysis published by the Gurgensen Group in 2017, in patients who received maintenance endocrine treatment, mainly letrozole, following platinum-based chemotherapy treatment showed prolonged progression-free survival, but there was no statistically significant difference in the overall survival. The PFS benefit was seen in patients with complete debulked patient and also suboptimally debulked patient. There are several ongoing clinical trials trying to confirm the efficacy of maintenance endocrine treatment, even to challenging the role of the adjuvant chemotherapy treatment in that setting. NRG-G1019 is a maintenance endocrine therapy in patients with a stage 2 to 4 disease. After primary cytoreduction reduction, patient will be randomized to adjuvant chemotherapy treatment, followed by the maintenance letrozole. The control arm without chemotherapy with a letrozole monotherapy and with a maintenance. The trial has started recruitment in 2019 and expect to finish the complete recruitment in 2027. This trial may or may not change our practice for adjuvant treatment and maintenance treatment in low-grade serous ovarian cancer in the future. Similarly, there's another clinical trial currently open for recruitment. There's a maintenance therapy with the AI in patients with ER-positive, high-grade and low-grade serous ovarian cancer or endometrial cancer. And after 4 to 6 cycles of adjuvant chemotherapy treatment, patient will be randomized to receive the letrozole maintenance versus placebo. However, single-agent endocrine treatment in low-grade serous ovarian cancer ethics law, particularly in recurrent setting. So the lot of trials look into the combinations, particularly including CDK4 and 6 pathway inhibitor. In normal cell cycles, the transition from the G1 to H phase is regulated by two cycling dependent kinases, namely CDK6 and CDK4. It has been reported there is a high prevalence of the in gynecological cancer, including low-grade ovarian cancer, about display of the aberrant cycling expressions. However, in the phase 1 single agent CDK4 and 6 inhibitor, the efficacy is very limited. There is a phase 2 study presented in 2000, I think around 20, which used the combinations of the endocrine therapy with ribociclib. In this trial, they showed a promising activity in the ER-positive endocrine gynecological cancer, including ovarian cancer and endometrial cancer. But particularly, they found 3 out of 3 responder in 3 patients with a low-grade ovarian cancer. So GLG is currently running a phase 2 trial of a ribociclib plus letrozole in recurrent low-grade serous ovarian cancer. The trial has started a couple of years ago and expecting to complete recruitment. By the end of this year, we probably will hear some readout in about 2 years' time. In addition, the first result of the pilot phase 2 study of a new adjuvant for Vestrum plus a CDK4 and 6 inhibitor was presented in ASCO last year in women with unresectable advanced low-grade serous ovarian cancer. At the presentation, 15 patients was recruited, and they could see quite impressive response. About half a patient eventually went into the cyto reduction surgery, and with the most of this patient with a complete surgical reduction. In Australia, we also have a Paragon study opened a few months ago using of the letrozole plus PI3CK inhibitor or CDK4 and 6 inhibitor. In this clinical trials, and there is a cohort for low-grade serous ovarian cancer. So it'll be a great opportunity for our local patient to access the combination of this treatment. Low-grade serous ovarian cancer is also characterized about the activation in the MAP kinase pathway, and potential targetable RAS and RAF oncogenic mutation has been identified in about 50% of a low-grade serous ovarian cancer patient. This, the result is from Anna DeFazer's lab. Can't read it very clearly now. I think about 100 patients with sequenced, and half of them have the RAS and the KRAS, followed by BRAF and LRAS mutation. The findings of the MAP kinase activation in low-grade ovarian cancers lead to lots of several clinical trials targeting this way. Sulimatinib is the first phase 2 clinical trial checking the efficacy of a MEK inhibitor in these tumor types. And about 16% response rate was noted, 15% response rate was noticed, and activity was found both in patients with or without KRAS mutation. Followed by this trial, there's another trial being published and presented in multiple gynae meetings in the Miller trial. So this is a multiple national, open-labeled, randomized trial, compare the efficacy of another MEK inhibitor versus physician's choice of a single-agent chemotherapy treatment. Although the primary endpoint was not met, but the response rate was quite impressive, about 24%. There was no statistically significant difference in terms of response rate and PFS of a MEK inhibitor and standard care of a chemotherapy treatment. Have to say, we all felt that the 24% response rate in the chemotherapy and chemotherapy arm was a surprise to most of us. In this clinical trial, the investigator found a trend of the increased response rate with the patient with a KRAS mutation. Therefore, it was suggested we need to use the KRAS to stratify the MEK inhibitor in this group of a patient in the future. So you probably everyone have heard about the GOG-218 trial. This is another large phase 2/phase 3 randomized trial for patients with a low-grade serous ovarian cancer. Again, patient was randomized to the two arms. One is the trametinib, one is the standard of care, which this time including both single-agent chemotherapy or endocrine treatment. At the disease progression, patient received standard care can be crossed to the MEK inhibitor arm. In this clinical trial, showed a very impressive progression-free survival benefit in patients received a MEK inhibitor that's 13 months versus 7.2 months in the standard arm. There was a trend of slightly improved overall survival. However, it's not statistically significant. But to bear in mind, in patients with a standard arm, they can cross over to trametinib at the disease progression. In patients with a KRAS mutation, the response rate was quite high, about 50%, and the response rate of a standard care in this arm is only 9%. I would like to point out the side effects of the trametinib single-agent treatment is quite significant. So looking at this plot, you can see skin rash is almost universal in this patient, followed by the fatigue, and diarrhea is another common side effect. As a result, 20% of the patients who are receiving the trametinib arm stopped the treatment due to the side effects. From the experience from the melanoma, we know that MEK inhibitor has a very limited activity in patients with the BRAF V600E mutation. However, the several case report has been published about the efficacy of the BRAF inhibitor in this population. Here is the two local cases about CA125 plot once receiving the BRAF inhibitor in the clinical trial. At the bottom, that the CT scan of the lady was resolving of the right side pleural effusion. This patient has been on BRAF inhibitor over 8 years now. And that PET scan showed a very early, quick metabolic response in another patient received different BRAF inhibitor in the clinical trial. At the disease, for that patient with a PET scan, and she come off a clinical trial after disease progression and received a subsequent treatment. But a few years down the track, when her disease progressed further with biopsy disease, BRAF mutation retained, and we got a compassionate access for her for the BRAF inhibitor. She had another excellent response with a second PFS about 18 months. Again, there's a lot of research done from the melanoma trial. We know that MEK inhibitor can cause inhibition of this pathway, but the feedback loop sometimes cause significant side effects, particularly skin rash, even skin cancer, and also decreased efficacy. Combination of a BRAF inhibitor and MEK inhibitor can increase efficacy and also potentially attenuate the loop feedback, therefore increase efficacy and potentially reduce the side effects. Therefore, it's quite logical to combine these two drugs together and to see if the combined treatment can improve efficacy. So this is a phase 1b clinical study presented with Ben Solomon in the AACR recently. This clinical trial investigates the efficacy, safety of a pan-BRAF inhibitor and a MEK inhibitor in patients with a mutation in the MEK kinase pathway. And this is the and low-grade ovarian cohort presented. So you can see in the waterfall plot, all patients had some various degrees of the reduction in the target lesion. The red bar represents four patients with the BRAF mutation all had quite significant reductions in the target lesions. Followed by the NRAS, 2 patients with the NRAS mutation had the same, has a response, but just to a lesser degrees. Response also having to also see in patients with a KRAS mutation. In the spider plot, I would like to point out that the response is quite durable, both in the responders and also in patients with a stable disease. Most of the patients with a stable disease remain on the treatment for a couple of years. We have a few patients eventually progressed after 2 to 3 years, so we have done a biopsy of these tissues. Hopefully they can contribute to the future research about mechanisms of resistance of this in these patients. This example of another clinical trial shows in the improved efficacy for further complete blockage of these pathways. So this study was presented in ESMO 2021 that used a combination of the FAK inhibitor and a pan-BRAF MEK inhibitor. In the cell lines, you can see the increased synergistic effect of the cell killing, and that's led to the phase 1 study. So this is a phase 1 study of a low-grade ovarian cancer cohort. You can see quite impressive response rate, about 60%. And response also even seen in patients have been previously treated with a MEK inhibitor. And a further cohort expansion is being conducted, and there is also a platform study looking into possible registration trial. There are other clinical trials ongoing, also looking into the efficacies of the antibody-drug conjugates and even immunotherapy plus anti-angiogenesis TKI and interleukin in ovarian cancers, including a small cohort of low-grade ovarian cancer. The take-home message today is chemotherapy benefit is relatively limited in low-grade serous ovarian cancer. The efficacy of a maintenance of endocrine therapy looks encouraging from the retrospective data. However, it need to be confirmed in the randomized phase 3 studies before we changing the standard practice. MEK inhibitors present a novel options for women with the recurrent low-grade serous ovarian cancers. But currently, as far as I know, they haven't been approved by FDA or EMA. Scientifically, and also based on the result of a few small phase 1 and 2 clinical trials, combination MEK kinase inhibition likely to provide the high efficacy, maybe even with reduce the toxicity, but registration trials are needed. Like ovarian cancers, the low patient numbers need to be taken into consideration in clinical trial design and also for the registration approval. Thanks.
So we're actually going to do questions now rather than the Q&A at the end. So we've got 5 minutes if we've got any questions for Bo. Maybe I'll start just by saying, obviously it's very difficult to treat this cancer, but I'm wondering, so you showed a couple of patients that had a really good response to BRAF inhibitors and a prolonged response.
Yep.
So is that, that was part of a trial? Are many patients able to access this therapy, or, how many patients, I guess, could benefit from those inhibitors?
So the access to treatment truly rely on the clinical trials, and most of them are phase 1 and phase 2 trials, so they come and close. And the Novartis occasionally provide a patient-based access program or co-payment program. The most recently, one of my patients has to do co-payment to access the BRAF inhibitor because the clinical trial has closed. So it's about $2,000, $2,000 to $3,000 a month.
Right.
Yeah.
Okay. We'll go.
I was just wondering, with the endocrine therapy trials that have been undertaken, what happens to women who are premenopausal in those trials? Because those are postmenopausal endocrine therapies that have been recommended.
Yeah, so in this opening trials, patients with a still functional ovary premenopause are excluded from the clinical trials. But most ovarian cancer patients, they would have the bilateral oophorectomy as a part of a primary site reduction surgery. So it's not very common for them still got intact ovary.
I was just wondering, you said that there's about 90 patients a year in Australia, and given that not all patients go on clinical trials, how feasible is it to actually do a clinical trial on this patient population?
So it's hard. Obviously, in the BRAF and MEK inhibitor trial, we have seen quite convincing efficacy data, but it's been a long battle with the discussion with the sponsors about the running a registration trial. For them, I think they got much less financial incentive to run a clinical trial. Also, they will be quite worried about the recruitment rates and also cost for ongoing clinical trials. So it's very hard to run registration trial.
Any other questions?
Thank you, Bo. That was a really lovely description of where we're at. What do you think about treating the patients who don't have a designated aberration in the MAP kinase pathway? So, about 40% have a kind of a really good one, 20% have like a pathway one, that leaves another 30 to 40% of patients. What do you think we should be doing with them?
So apart from mutation screening, we have seen response, but definitely reduced response of the MEK kinase pathway inhibition in these tumor types. And from our very limited experience for other trials, we have seen very good response about combined immunotherapy with anti-androgenous treatment like sitravatinib, but cannot tell if the response is generated from the anti-angiogenesis or combined immunotherapy.
Yeah, I guess the availability of BEV for combos has given us like one more
Definitely.
shot in our armamentarium.
Yeah,
When it's really frustrating, isn't it? Because you presented beautiful data by two different groups.
That's right.
Slightly different approaches, but
Yeah.
really probably taking out the same thing. And it seems to be frustratingly good.
Yep.
Frustrating for everyone who can't get access to it. Yeah. Thank you so much.
Thank you.
Okay. If there are no further questions, we'll let Bo off the hook.